So welcome. My name is Dr. Darian Sutton. I'm an emergency physician by training, and I'm also a medical correspondent for Good Morning America. And a little bit about me. Growing up in Mount Vernon, New York, my first experience with Alzheimer's disease was with my great-grandmother. Unfortunately, in my early life, I only knew her as she lived with her disease. But one of the first memories that I've had is watching my mother, her sisters, my aunts, work for her and understand her and care for her. And I attended a lot of hospital appointments, sitting on the floor as a child, observing the interactions between my parents, my family, and the providers that were taking care of her. And when I became an emergency physician, that experience was kind of profound for me, because I realized as a physician in the emergency room that there were so many that shared that lived experience, and there were so many that were actively going through it, which is why I'm so honored today to moderate this panel of incredible people who can provide such incredible resources, information around this topic. And we can leave this conversation feeling educated, inspired, and ready to make some moves to make a change. And so I wanted to introduce our panelists. I'm going to start first with Helen Henley. Helen is the founder of the Chief Executive Officer of Crescent Advising. She's the Administrative Director of the Community Access Recruitment and Engagement, otherwise known as CARE Research Center at Massachusetts General Hospital. Her expertise focuses on the implementation of public and community health models into clinical research infrastructure and community engagement strategies for engaging historically marginalized communities in research. I also want to introduce Mr. Michael Kincaid. He's recently accepted a position, well, not recently, 2019. The pandemic makes me feel like time has flattened, but he has accepted a position as a communications and outreach coordinator at CART, or MADRC in 2019. And together the team is working to educate and recruit those underrepresented in research. One thing that he wanted all of us to know, and I think it's really important, is that he has over 20 years experience working in this field, and personally has more than 25, almost 30 years experience living with this disease, and not living with this disease personally, but working with his family and understanding this disease on a personal level. He's also produced and hosted the award-winning cable television program Age-Wise Boston, and represented the agency on several citywide collaborations. I'd also like to introduce Ms. Stephanie Monroe. She is the Vice President and Senior Advisor of Health Equity and Access at Us Against Alzheimer's, a national advocacy organization based in Washington, D.C. As an attorney with 3 decades of federal policy experience, Stephanie is a former Assistant Secretary of Education for Civil Rights. And prior to serving in that position, she ended a 25-year career on Capitol Hill after holding a number of key staff positions in the United States Congress, including Chief Counsel of the U.S. Senate Committee on Health, Education, and Labor, and Pensions, and Staff Director of the Senate Subcommittee on Children and Families. I'd also like to introduce Carlos Olivas. He is a devoted family man and a primary caregiver, embarked on his transformative journey in 2015 when he left his career to care for his dad living with geriatric Alzheimer's dementia. His role as a social media content creator amplifies his commitment, reaching a global audience with heartfelt narratives and valuable insights. And he's a proud member of the We Are HFC Care Influencer Care Squad and a champion caregiver with caregiving.com. Thank you all for coming today. I'm so excited to have this conversation with all of you. And hopefully, again, we'll be able to provide some education, some awareness, and some comfort for those who are listening today. Michael, I wanted to start with you, and I wanted to ask you the question, based off of your focus on your work in reaching and recruiting those who are underrepresented in research. Talking about research before this panel started, we talked a lot about how many of those who are minorities were excluded from research and often end up underserved in these important areas of treatment. Can you describe some of the strategies you use to employ and to successfully recruit diverse populations for dementia research?
Well, thank you, Dr. Daniel. One of the things that we do at the Massachusetts Alzheimer's Disease Research Center is we have it's not a program, it's an initiative called Bringing Research to the Community. And I'm a firm believer that researchers need to go to the community before they need to go to the community. Get to know the community. When Mission Baptist Church is holding their annual barbecue, show up, but don't show up with I've seen this. Don't show up with flyers and sign up sheets. Show up with food. Show up. If you make a killer, potato salad, show up with the potato salad. be there. Now, if you buy it at the grocery store, not a knock on them, but don't bring that. But just show up when you don't need to show up. Get to know the members of the community uh, and on a first name basis, so that when that time comes and you need to reach out to the health ministry, you need to reach out to, a certain particular group or organization, they see you as an ally, as opposed to, and I say this deliberately and please don't be offended, they see you as an ally, not an invader.
Mm.
They know that you're there to help instead of take. And that's the model that I've always believed in.
It's so important to show up not empty-handed and hopefully avoiding potato salad that has been bought in a supermarket, but I'd still try it. But I also find that when we talk about research and the lack of inclusion and diversity in research, there's a lot of fear that happens. Mainly, we have a fraught history with research in marginalized communities. How do you tackle that fear when you're talking to someone who might be new to research and participating in trials that are really important?
I had the joy of being at a community gathering, and there was an individual from our local cancer research center, and she literally started her conversation out talking about the elephant in the room. Why is it that folks don't participate in cancer research? And I'm not going to lie, I was blown away with that, because I went, wow, that's a creative way. Let's talk about the problem before we talk about the solution. And I took from that. So a long answer to a short question is, be honest about it. It's like, yes, we as people of color have a history, not always positive, of participating in research, both willingly and unwillingly. But let's also talk about what the research community has done to make sure we never relive that past. Let's
And I
show
would
up.
also,
So
yeah,
that's my
I'll
answer.
add that there's different types of research. And so I think we have to explain to people that not all research involves what people would call experimentation, shots in arms, right? Surveys, participating in surveys that might come to you, that's a way of getting research. To find out what matters most to you, for example, that's a way of participating in research. Participating in family history. People want to know, is there something, a genetic thing that they can see? That's a way of participating in research. Diet and exercise programs. There were programs that were giving people YMCA memberships to go in and get on a treadmill for free. That's research. So explore all the different types of research. I do think that we overestimate the amount of fear that communities have for participating in research. And frankly, many times it's an excuse not to ask.
Yep.
So 80% of people who should be participating would love to have the opportunity or never asked. And that in and of itself shows a bias. We're not asking them because we are afraid of them saying no, which is their right. That's what informed consent is. We're not asking them to participate in research because we're afraid that they won't follow through. We think they'll drop out. And that's a bias, right? And so, and there are other reasons why we're not asking them to participate in research because we think they're not healthy enough to participate in research, which is really trying to create this perfect person with no chronic conditions to research on, and then send these medicines into communities with tons of issues of hypertension and obesity and heart disease and other things. So we've got to, as patients, demand opportunities too, but burden can't fall on us squarely. Doctors should be asking people for research and setting them up as much as they can to say yes.
I'm sorry.
I just want to piggyback on that real quick, what Stephanie said. One other thing, let's not underestimate linguistic ability. There's too many cultures out there, especially among the elderly group, that people say, well, we don't do that because we're not sure they can understand, they speak English properly. Without even bothering to realize, you're talking a 55 to 60-year-old group of elders who were born in this country and therefore are very fluent in English. So let's not forget linguistic issues also.
It's really interesting and important. Many times, my naive mind before I became a physician was thinking that research was that typical feeling of you're being subjected to something negative and you're likely to have a negative outcome because you feel like you're being tested. And a lot of that is fed through the history that we know has occurred with research in marginalized communities. When you think of those landmark studies that we all remember, you know, we talk about the syphilis study and we talk about other studies on oral contraceptives in Puerto Rico. And so I think it's really interesting when Stephanie brought up that important point, which is that research is more than just studying a specific thing. It's including a variety of different outcomes, and it can sometimes even benefit you to participate.
Yeah, I've often said the first person cured of Alzheimer's will be in a clinical trial. That's where the breakthroughs are going to happen. So like the lottery, right? If you don't win, if you don't play, and we need to participate. We need to participate.
You know, Helen, I want to jump to you. I have a question. You know, you work to implement public and community health models into clinical research infrastructure, and you often work a lot with the socioeconomic factors that influence the prevalence and the outcomes of dementia. So what do you think can be done to mitigate the impact of some of these socioeconomic disparities on dementia care and the support services that are available?
Yeah, so socioeconomic factors are just one part of social determinants of health, which are multiple factors that not only are a part of historic injustices that have made it harder for people to access care, to be a caregiver, and to participate in research, but also current policies and practices that are happening today that make communities invisible within research. So it's really these historic and current practices that make it these social determinants of health so important to take into consideration. So for example, where I live in Boston, the neighborhood of Roxbury is predominantly Black and immigrant population. There's no public transportation that for a subway to get there. There's only buses. It's a food desert. It's a heat desert. There's less green space in Roxbury than in Boston, which is labeled one of the greenest cities in the United States. And in addition to that, 3 of the major hospitals sit directly adjacent to the neighborhood of Roxbury, 2 of which have Alzheimer's disease research centers in there. So we know that things like built environment, racism, and these historic social economics factors also impact increased risk to dementia for populations that are already at high risk. So what hospitals and policymakers really need to do is look and see what data is missing, because these communities are currently invisible, and there are plenty of ways to build in from public health models, through communications models, through other factors that do a really great job at reaching diverse communities. And I mean diverse very intersectionally, in a way to make sure that there is representation for many communities to be part of research, and for many caregivers to have their needs met when they want their family members and themselves to participate in research. So I'd say we need to look at what data is missing, because those people exist. We've just created systems and infrastructure that makes them invisible.
It's so valuable that you talk about data, because I've always learned that you can't change something you don't measure. And I think it's really important, and it's one of those statements that has stuck with me through time, because I always see examples of it when you look at research, when you look at the disparities, when you look at the lack of diversity in these data sets. And my question to you is, when you're looking at the socioeconomic effects, because I also think that as physicians, we sometimes forget that the whole outcome of a patient is not just on the medication we prescribe, but on the life that that person lives. What do you say to people who live in those communities right now, who are looking for some type of assistance to be able to help their community? What ways can people step out of their house and help their community do better, to get better results?
So I think one thing that we need to do within hospitals, so we need to find more ways for people to participate in research besides just being a participant in research. So there are plenty of IRBs, each an institutional review board, each institution has one, and those have positions open for community members. But we need to create more community IRBs that are being led at the community level. We have to find ways to have community own research and own research registries. There's a lot of wonderful examples in indigenous communities that have really created tribal ways to own the research. And so if we can build more infrastructure at the community level with academic industry funding, I know that's not necessarily what these research institutions want to do, but by doing that, you'll create a more bidirectional benefit to last in the community, as Mike was saying, to show up in the community, have people eventually participate in research and have that research owned by the community. So there's such a wealth of knowledge within the community already. Caregivers know what they need. People living with dementia know what they need, and people who want to participate in research know what they need. So we need to fund that infrastructure to make sure that that wealth of knowledge can be really concretized. And there's already great examples for how to do that. Again, indigenous communities across the United States and in New Zealand and in Australia have been doing a great job at that.
It's
And
so
Dr.
helpful.
Sutton, I would just like to add too, I mean, I love that you brought up the issue of data. Data is so important, and it is a part of research in general and understanding and being able to visualize. So at Us Against Alzheimer's, we've created National Alzheimer's Disease Index, where we're able to map where people live who have Alzheimer's disease throughout the country. And then we're able to see what infrastructures exist and create this vision of things that produce barriers, right? We know where the neurologists are. We know where the PET scans and things like that. So then we can lobby Congress for more in a very precise area. One of the things that's interesting is that we also were able to produce a report looking at place, looking at social determinants of health. We looked at the top 20 counties of in the US that had the highest rates of Alzheimer's disease and the bottom 20 who had the lowest rates. And we found very predictable similarities, right? All the counties in the US that have really low rates of Alzheimer's disease are doing certain things correctly. The other counties are doing other things. But the thing was we found in common, it's not just the built environment, it's also the lived environment, right? There are things that people can do to modify their social determinant of not just health, but of risk. And those include things that often aren't mentioned by doctors, I would say, because maybe they're not good behavioral lists, but getting good night's sleep, getting exercise, doesn't have to be at a gym, walking up and down the stairs with cans, good nutrition. Yeah, we want you to access really great clean fruits and vegetables, but with what you have, right? Can you make a nutritious meal that's a cleaner, that's not fried as much as possible? I always say everything in moderation, but there's certainly some healthier choices that we can make. And again, a lot of these are strategies that can modify risk, not just for Alzheimer's, but for heart disease. Heart health is Alzheimer's, brain health, other chronic conditions like diabetes, which we often find with patients. So just as an example, we found that the cost of Alzheimer's disease to our Medicare system was about $17,000 per person. If that person also had diabetes, it went up by another $10,000 per person. And so our doctors also need to mention those things to people. I've been surprised by people that I've known that are 350 pounds that go into the doctor's office. Doctor doesn't even see that. Doesn't even mention, have you thought about losing weight? These are some strategies to help you lose weight, right? It's like they're collecting all this data, but what happens to that data in the office? If not to look the person in the eye, and I don't know why we don't do that. Maybe we feel ashamed or we think they already know, but we've got to be much more proactive and honest when we see people. People will often do things that a doctor suggests that they themselves wouldn't be empowered to do, but the data is showing us exactly what we need to do. And finally, reports have shown us that if we implement some of these risk modification strategies, we could prevent as much as 40% of people from going on to develop Alzheimer's. That's huge.
That is incredible, especially when you think about the small changes we can make from a systems level, from a provider level, that can affect change on a personal level with patients and their lives, that can truly change their lives for the better. I want to zoom in on that personal experience and invite Carlos into this conversation. Carlos, In your experience, in what ways has cultural competence played a role in providing dementia care? You are a primary caregiver for your dad who is living with Alzheimer's disease. So I'm curious about how you believe that we can influence healthcare providers to ensure safety and care and cultural sensitivity around that.
It's a great question. And when I began this journey, my brother took my dad to the primary care physician. The doctor was Latino, elder, and diagnosed my dad with MCI, mild cognitive impairment, and didn't give us any other information about what is next. A few months after that, doctor retired. And then we were left to sort out the next steps by ourselves. I think it's driven by education, educating the doctors about Alzheimer's and other related dementias, sharing what is out there now from researchers to other dementia practitioners, how to approach families that need essential support. What is the essential steps to take to get a referral after being diagnosed with mild cognitive impairment? How to adapt with communication or even lifestyle adaptations, like nutrition, good sleep, exercise. How can we make these little incremental steps to have a strong impact with our loved ones? And I think it's essential that education is the key for the medical professionals and healthcare systems, and then it can trickle outward to the family care partners like myself and get them up to speed, bridging the gap between what medicine and science is doing versus what care partners and care family givers are doing at home, so we can tackle this in a more comprehensive, compassionate way.
I appreciate your words and I appreciate how you share your personal experience, because I do believe that that provides some of the most valuable forms of education I as a physician can ever have. You spoke about when your father was first diagnosed with mild cognitive impairment. Can we take a step back to that time? If you could speak to yourself in that period of time, how would you explain this better? How would you do a better job of educating yourself in a time when you probably had very little answers?
Well, I would probably take a deep breath, like I just did, and absorb it. Maybe take a trip to a library, maybe talk to a social worker, maybe find out from someone who is much more knowledgeable than me. Getting to a resource that can educate what the aspect of mild cognitive impairment is. Because there's many triggers from what I know now that can initiate mild cognitive impairment, anywhere from vitamin deficiency to a brain tumor to the onset of dementia. Is there something that we could improve upon to have an outreach to people through community engagement that can educate the community, especially family members who would probably go, "Oh, Theo is just crazy. He's always been like that." But Theo may be having some life changes inside the brain that we cannot see. We cannot see this invisible invader. And we just want to understand how to best serve them. We can kind of recognize the early warning signs, how we can understand how to communicate with medical professionals to convey what our observations are and have an impact, have the medical professionals take us seriously, that mom's losing her glasses and the glasses have been on her head all day long. Sometimes it's normal. I do it all the time. But there's times where there's a series of symptoms that expose more of mild cognitive impairment and memory loss. So how do we identify that, and how do we communicate and educate communities about this. And I believe it all starts with medical professionals and our community leaders.
What you brought up are some incredible points. Even talking about some of the signs of early signs of cognitive impairment, early signs of dementia, early signs of Alzheimer's disease. As a physician, I often, and given this type of question, my parent has memory loss. How do I know if memory loss is associated to normal memory loss, which an estimated 40% of Americans experience after the age of 65, versus are these early signs of early onset dementia? Are these early signs of Alzheimer's disease? And so there's always moments where I think that there's a lot of need for education, just in discussing the difference between forgetting where your keys are versus forgetting a common recipe versus forgetting where you the address or directions on some place you normally go, forgetting obviously your family members' names, asking repetitive questions. These are topics that I think are not often talked about, so that we can be better educated as caregivers to make sure that we identify problems early so that we can intervene. And also, you made important points toward the support. And so I want to spin around back to you, Stephanie, because you are an attorney with over 3 decades of federal policy experience. I'm curious to know how, since you've been kind of in this process for so long and you have so much experience, how collaboration between healthcare professionals like myself, community organizations, and policy can enhance equity in dementia research and ultimately the delivery of care that is equitable, fair, and appropriate and accurate.
Well, that's a big question. And let me start in this way by saying that even with all of that experience that I've had working on the Hill, working in healthcare policy, I was not prepared for almost 10 years ago when my father received a diagnosis of Alzheimer's. All my head knowledge just sort of flew away at that moment. And we had to fight for the diagnosis. I had to go to 3 different doctors to get a confirmed diagnosis. And I had to insist on a PET scan because they couldn't tell whether it was a frontal temporal type of dementia or Alzheimer's type of dementia, which would change both symptoms, our planning, and treatment. So that was a struggle. And then also the experience of, here's a diagnosis, and you're sitting there like receiving a cancer diagnosis, like no idea. I had no idea where to go next, no idea what to do, no idea. It was like, here, take these pills, didn't ask any questions, just all the things I knew you should do as a patient. I'm just like, oh my God, what do we do with this? There are some places in the country, I think, that do a better job of coordinating and collaborating. But unfortunately, I think our healthcare or our sick care system is much more siloed than it should be. The left hand often doesn't know what the right hand is doing. We have problems with even getting medical records to be shared, office to office, inside a hospital. You may have one corridor that's using Epic and someone else is using something different. We don't have a system where your medical record follows you. We don't have like a medical passport. You go into different doctor's office, and it's especially challenging as you get older, and you're asked, what medicines are you on? You're asked all of this to repeat all of this stuff that technology could be really used to help. And I think those things create frustration, and those things create potential gaps and misdiagnosis and breakdown in healthcare. I think if I look at sort of an example of what I think works better are places that become like your medical home, like federally qualified health centers, that do a great job of taking care of people up until the point where they reach geriatric age. And for whatever reason, they are losing that center. But a healthcare home, right, that is a place where you go for sometimes even specialty care, mental health care. They train people on how to eat properly. They've got social services right in the building. It's a one-stop shop. They run all your tests for you. You've got one doctor that's sort of following you and tracking you. I hope that that's a system that we move more toward, or people find a doctor in primary care. I think we did a great job of making sure through Affordable Care Act that people had access to healthcare insurance, but we haven't done a good job making sure people have access and know how to use preventative health care. If you look at our gross national product, and this is a policy issue, only 3% of our entire gross national product in the US is spent on prevention. The rest of it is spent on dealing with sick people. And we've got to flip that narrative on how we do this, because our aging population, we know I mean, you know when people are born, how they're going to age, and so you know when this boom's going to hit. And we've known we don't have a good long-term or any really consistent federal long-term health policy. We don't have places for people to go. We're not encouraging home builders to build single level housing to make it easier for caregivers and their loved ones not to fall, to be able to remain at home as long as possible. I'm just going to shed the light on it. I'm paying with my family members about $16,000 a month to put my parents, my mom is 91, my dad is 86 with Alzheimer's, to put them in a safe assisted living place. And I say safe. It's not ideal. I don't think there's an amount of money out there that can make it really an ideal coordinated system. So that's something I think we need to look at seriously. We need to see what other countries are doing to really build in that really love and respect for caregivers. We don't pay unpaid caregivers. There's 17 million people out there serving as an unpaid caregiver, losing work, losing productivity, get a fear of getting fired from their job because they take up too much time. We're the last industrialized nation in the world that does not have a paid family and medical leave policy. 30 years ago, we're getting ready to celebrate, I believe, the 30th or 31st anniversary, we passed unpaid family medical leave. And some insurers, I mean, some companies have been great, smaller businesses, in that they will step up and offer some care and the assurance that you're not going to get fired. But we've got to do better than that. So we need collaboration. We need better coordination. I don't think we're there yet. I haven't found strong systems that do that. I'm not going to call out ones in particular, but I feel like there's a national effort that needs to be put in place where we have that type of coordination and collaboration among social work, healthcare providers, caregivers, mental health. We need to know what each other is doing. We need to be able to plan for the future. We need resources to help people with this burden. And I'm saying it is a blessing to take care of a loved one, but it's also a financial burden if you're not prepared. And it always feels like you're settling for something that's not what you would want. And so the guilt, and we also see that caregivers get sicker and die before because of the stress. So we've got a lot of work to do in this space. And I think Alzheimer's, frankly, is unique. You can live for up to 20 years with this disease, 20 years, which is, again, it's wonderful, but it's really capacity challenging.
I just want to echo this, echo what Stephanie just said. I mean, there's a burden and there's a lot of complexities that comes along with being an Alzheimer's caregiver. Understanding this misunderstood disease and unlearning what you've learned and relearning something new.
Yes.
Midstream. And for me, I'm middle-aged and I am having a hard time with it. But there is some relief. I have a great employer that allows me to take time off and it's very compassionate and understanding of my journey. But I wouldn't be able to do that with my old employer, my old career. I wouldn't be employed.
Mm-hmm.
So it's a struggle for family caregivers.
The struggle is often goes on. It's not often heard. It's not often felt, and it's one of those reasons why it inspires me to continue having conversations like this. I never realized the work of family and caregivers until I became a physician. And often I saw early on in my career that many would kind of admonish those who bring their parents in, like, oh, here they come again. And many times these people had no other option other than to bringing them into the emergency room, because as Stephanie was saying, they have sufficient sometimes resources, but nothing is ever ideal. And when we have someone that we love, it really changes your perspective of the entire situation. And unfortunately, there's so many centers that are not figuring out how to do it. But Helen, you had made a point about in certain indigenous communities, how this system seems to be working well. What signs in those communities worked well that you saw that might be able to help provide some awareness on how to fix the system?
Well, Dr. Darian, I think to your points with the data, we need to look at not just these deficit models, but also resilience factors. So looking at what works for specific communities and not trying to find ways to push white, often westernized approaches to engaging with research on communities that that may not be the best way to engage them. So obviously saying that that is a resource, that is a way to understand your diagnosis, your community, but also that the ways that are important to your community and bring resilience into your community are just as valid and important. So that is one way, of course, community ownership. And then also just, I know we're not going to solve equity in Alzheimer's research today in this panel, but just looking at how we're talking about inclusion and diversity. And my colleague, Dr. Jonathan Jackson, who I saw was in the chat, he always says, you know, if you build a meeting from the mindset of making sure that it's a dementia-friendly meeting, it'll be easier for everybody, you know, for wayfinding, for being able to access the meeting, for, you know, if you're in a busy hospital, getting there, so many different ways. And so when it comes to research, we also need to build research in a way that looks at those resilience factors and emphasizes inclusion and diversity, because when people who have been most marginalized by research, who are at highest risk for Alzheimer's disease, when they benefit, everybody will benefit. And that will be so important for hopefully finding a cure for Alzheimer's disease. So I'll benefit, people who are at the most privileged will benefit if we really optimize and build research for people who have highest risk and have been most marginalized in the disease.
And if I could just add one thing too, this is an exciting time because we, through research, now understand that a person could begin to have brain changes that look like it's going to lead into Alzheimer's 20 years before the first symptom. So if we can get people really early on through genetic testing and through blood biomarkers and other things and looking at risk factors, right? And have interventions happen, there might be medicines that could help slow the progression of this disease in individuals. So it's really exciting. Unfortunately, you know, the politics of it sometimes preclude that from happening. So for example, the US Prevention Task Force has recommended against doing annual routine screenings of people for cognitive impairment. At the time when they did this several years ago, we didn't have a drug to market that was targeting early people. Maybe they'll change their mind, but those are the rules that are being made by politicians about how physicians get paid for things, what you can do. I mean, you know this more than I. Recommendations on, you know, we know it's changed, you know, do you get a pap smear? Do you not get a pap smear, right? Baby on the back, baby on the side. What do you do? Screening for Alzheimer's and mild cognitive impairment, not screening. Those are decisions that are made by separate boards. So we need to be advocating for what we need. To get on some of these new medications, if you're a doctor and you feel like it's appropriate, you have to be screened early. You have to be screened in the various earliest stages of the disease. And most in the Latino and African American communities are getting screened late stage. When you have all this severe memory loss, when your brain has started to atrophy, when you're having problems speaking and walking, that's when we go in or someone notices. But we've got to change that. We've got to intervene early because the treatments that are being developed are really trying to be more preventative focused, as well as we know the lifestyle changes. So early has got to be better. And we've got to tell our, demand our policymakers to keep up with the science. Y'all can't afford to be 20 years behind what the science is saying.
I noticed that we're a culture of medicine in this country of acting when something has already happened. And we, as you said, don't value the importance of prevention. And so the key on flipping that script and focusing on prevention so that we can prevent negative outcomes is really key to this and pushing for that. I'm so happy that all of you were able to provide such great opinions. We're coming to a close, unfortunately. I wish that this panel could last at least another hour because I have many more questions, and I'm sure many of those who are watching do. I want to end with you, Carlos. You share so much about your experience. What advice can you give to those who might be at the beginning of their story with a loved one or a caregiver who has this diagnosis? Or what support would you give them if someone called you for assistance?
I would lay out a plan, talk to your primary care physician, tell them exactly what your observations are, the maybe they align with the 10 early warning signs. Ask for a referral to a neurologist, get blood work done, rule out all the possibilities that it could be something else before we start looking into Alzheimer's and memory loss. And then build a support team. You cannot do this alone. You have to have support behind you, family, friends, your medical professionals, your mail person, people around you, your neighbors. They can help you, go through this. And when you reach out, you may find somebody that's been there before. And that is your resource, your go-to person. Caregiver support groups like HFC, I'm a part of the caregiver support group system. It's invaluable. I go there once a week to connect and share my experience and gain support from others. So support is vital in many aspects of this caregiver role.
It's incredible. Thank you so much, everyone, for their insightful opinions and education in this panel. Carlos, Stephanie, Helen, Michael, I appreciate your time tremendously. If you're watching this panel in your audience, we have a follow-up. I was supposed to remember where everyone was supposed to go next. I've obviously fully forgotten that. But we'll direct you to where to go to the next chat room so that you can follow up with the next part of this conference. It has been so wonderful spending time with you all. Thank you so much for your time. And for those who are watching, hopefully you found something helpful from this conversation. All right, so we're gonna log out soon. You would think that I'm a pro at Zoom, given the pandemic. This is where I just sit awkwardly and wait for someone else to assist me.
We're gonna have a 5-minute intermission, and then if everyone can meet back in the lobby, that'd be great. I'm gonna end.
Awesome.
Thanks so much, everyone. This was wonderful. Take care.
Thank you, everyone.
Thank you.